This is Eric Penniman, your Executive Medical Director. I want to introduce you to a short video that I created along with Dr. Randy Pardue from the Trinity Medical Group. Randy is a longtime family doc and a lead partner at the Trinity Medical Group, which became part of Summit Medical Group on September 1st. Trinity Medical Group has had an innovative program to help their patients develop lifestyle changes to reduce their insulin resistance and risk for cardiovascular disease. They have been using CIMT, or Carotid Intimal Media Thickness testing, for a few years now as a means of identifying a patient's risk and especially to help them motivate their patients to take their health seriously and follow some of the evidence-based guidelines. As you know, CIMT has come before the Quality Committee on 2 separate occasions. The first time it was discussed at the Quality Committee was without Dr. Pardue's input. That discussion factored in the clinical evidence and the fact that the writers of UpToDate did not recommend using CIMT in the clinical setting. However, the writers of UpToDate did validate that CIMT has been validated and found to be a good predictor of potential cardiovascular events. They felt that in light of coronary calcium score that it may not be useful. Dr. Pardue, however, had attended a preventive cardiology conference at the Cleveland Clinic several years ago and learned how the Cleveland Clinic is using CIMT to follow patients longitudinally. Dr. Pardue has been doing this and has found this to be an especially good tool to help their unmotivated patients to become motivated. He shares a story of one of his patients in this video, along with some of the idiosyncrasies with CIMT. So in summary, CIMT can be a tool that is low cost, which is about $150 per patient, that can help drive evidence-based medicine. And it is for that reason that the Quality Committee recommended approving this at Summit Medical Group. Because CIMT is an ultrasound/duplex technology, the operator variability, it can be very significant, and it's very important that there's a quality assurance program to ensure that the sonographers are getting reproducible results. So please sit back and listen to this short interview. Thanks.
You do a study that's if their variants, their arithmetic variants are 0.002 millimeters, 2,000.
Wow.
Is what they can reliably reproduce on that study.
So Randy, tell me a little bit about when you first started using CIMT, Carotid Intimal Media Thickness testing.
Yeah, well, sometime back, several years ago, I went to what was really a preventive cardiology conference up at Cleveland Clinic, and was really impressed by the array of docs that were there, just from lots of cardiologists, but also internists, family doctors, some of the Cleveland Clinic experts, and I was astounded with some of the former interventional cardiologists who were hardly doing any interventions because their prevention was working so well. And so anyway, but in that context, I learned about using, they talked about coronary calcium score, but also learned about using CIMT as a way to not only get a great baseline measurement like we do with coronary calcium score, but also to sequentially follow folks. And that's because of the fact that the IM measurement that we get is actually reversible. So it progresses, showing sort of progression of arterial inflammation that's actually reversible.
So tell me, in your practice, if you're working up a patient and you plugged in their ASCVD risk using the Framingham calculator, and you're trying to decide, okay, maybe I'll get a coronary calcium score, or should I get a CIMT? How do you choose which patient that you're going to do a CIMT versus the coronary calcium score?
I think it's not unreasonable. And first of all, let me just say, I don't have a real scientific delineation between those two at this point, but I can talk about what, sort of what I think is reasonable to do. I think with a coronary calcium score just costing $100, and obviously giving you the specific data relative to the coronaries versus the carotids, I think you could make an argument to do one of those in everyone that fits that risk category. So anytime, so if I'm really, if I'm wanting to use that data to decide on using a statin and not have it as pure primary prevention, but to actually know some data about the arteries, I think it's reasonable to do a coronary calcium score on all of those. The thing though is that at that point, I don't really think it's very useful for following people, and so I think that's where then I would start with the CIMT. So I have something where I can actually follow progress. Now I mean, after if I get a 0 coronary calcium score, after 5 years, I'll do another one just to see if they've developed any. But honestly, if I got an 80 or something, I just don't know how helpful that is. I'm sure other people have their opinions, but that's where I love to have that test that I can really follow progress, you know.
Yeah, that makes sense. So somebody who maybe you plug into the calculator and maybe it's a 50-year-old male whose only risk factor is being overweight. He doesn't have diabetes, he doesn't have dyslipidemia, his blood pressure is great, his A1C is 5.2, and so he doesn't have any insulin resistance. And so do you find it helpful in somebody like that to determine whether or not a statin would be appropriate?
Absolutely, yeah, because again, if you were looking at him and you didn't have the numbers to argue for a statin, then, you know, again, you get some significant plaque on a CIMT, or if you get calcification on a calcium score, then again, you've got disease and you can make the argument for that. And so to me, those are cases when I'm looking at someone and I see risk, but we don't have the numbers to determine risk. Now, what I am more likely going to do in that guy, and it really depends on the amount of disease we find, but if I just find like a thickened IM area, then what I'm going to do is our lifestyle stuff with him and watch for that to reverse and make sure he doesn't develop plaque going forward. Now, if I do that guy and he's got a bunch of plaque, that's where I very well would start a statin, you know.
Sure. So tell me about, you guys have a pretty innovative approach to addressing lifestyle in patients and have had some really great success with your patient population. And you guys are partners in a wellness fitness center. Tell us a little bit about how you approach wellness, particularly cardiovascular wellness.
Probably in relative to cardiovascular disease, and then really more centrally metabolic disease reversal, but obviously that's strongly tied to cardiovascular disease, is we have an 8-week program that we call Launch that we send people to, and they go 3 times a week for about an hour and 15, hour and a half each time. And it's just we start out sort of getting them started on the diet that we think will reverse their disease, and then really educating them about what's happening with insulin resistance, what's happening with the various factors that lead to endothelial damage and coronary disease, and get people so not only to get them on a diet, but get them to understand why the particular things we're doing matter. And then each session they have exercise. We teach about stress, and we think we've developed a fairly good stress teaching protocol, which was always really hard, but I think we've gotten better at it. We teach them about good sleep. We try to equip people in that 8 weeks to really begin to have changed habits, you know, and to do the things they need to do to really change. And so that's the essence of it. Now, obviously, there's a lot of details involved in the 8 weeks, but we also are doing more one-on-one coaching, and we just find some people want that and/or respond to that. And so just the wellness coaching where the coaches are implementing the kind of things I want to do to reverse their disease. I say that I look at the way Jesus did things and realize that that the idea of discipleship, or in this case, what we call coaching, is just built into the fabric of the universe. people don't generally just respond to do that. People respond to someone that coaches them through it, you know.
Yeah.
And so that's really sort of the principle. And we're just finding we're finding our true changers are the ones that have been coached, you know.
Yeah, that's awesome. So when you're doing the coaching, and obviously you have wellness coaches and athletic trainers and people like that, are patients paying out of pocket then for those services, or do you get insurance to cover any of that?
It's all out of pocket.
Okay. Yeah.
The 8-week program costs $500.
Okay.
What we're charging for it right now, which we think is a pretty good bargain.
Yeah, it sounds like a good bargain. Yeah.
But yeah, so we've toyed with the idea. We would love to eventually get some insurance payment. Although what we found, if they've got skin in the game, they just inevitably do better. Yeah. We've had people, for example, we've had employees that we've totally scholarshiped and and they are just almost inevitably the ones that drop out halfway through.
Let's talk about how CIMT may be used to help motivate your patients, you know. Yeah. So maybe share a patient story, leave their actual name off,
yeah,
you know, but share a patient story of how that's been useful.
Well, the first guy that comes to mind is one that was, and I can't remember the details right offhand, but just say he was having some numbers that were worrying me, some cholesterol numbers and such. And I had just really worked on, well, I wanted him in particular, I wanted him on a statin. And, but I also was really working with him to try to get him exercising and doing various things. And he was just nonchalant about it, but he would come for his physical every year.
Yeah, right.
He'd come and we'd get those numbers, and I'd say, hey, we really need to do something here. I'm concerned. And so finally one year I got him to do the CIMT, and he had very significant, his arterial age was like 20 years over his age, which meant a significantly thickened IM section. And he had some plaque on it as well. And I remember sitting down and him looking at it and me talking to him about it. And he just looked at me and said, okay, doc, you've got my attention. What do you want me to do? And that was just really, I was like, and since then I've seen numerous ones where that kind of concrete data was like, okay, I get this. You're not just giving me numbers now. You're showing me what's happening with my arteries. And in this case, just a few inches from the brain, you know.
Yeah, right.
So he really, and this guy, it's really interesting. This was probably, I don't remember how many years ago it was, but he's just been a model patient since then. He's actually just finishing a hiking of the Appalachian Trail. But we also, the other thing is, are people that are, say people we're working with, and they are, they're doing the program, but maybe sort of partially, and they're sort of halfway engaged, and we get their numbers back, and they really haven't had significant improvement, or say even they've gotten a little bit worse. Again, they're actually watching, so their lack of engagement, they're seeing what happens, and then when we get them engaged and then show a reduced arterial age, etc., it's just unbelievable how motivating that is.
Yeah.
You know?
In summary, Dr. Pardue mentioned that they currently use an outside company called Carotid, which has been very validated and proven to have very good reproducible results down to the micron level. They do offer a training program that we could send an ultrasonographer to get the extensive training and ensure that the reproducibility of the results would be noted. I hope this has been informative and the board and others can better understand why the quality committee recommended the continuation of CIMT at Trinity Medical Group.